So let's talk about some of these changes that happens, or continue talking about the changes that happens during pregnancy. So there will be changes in hormones during pregnancy, and this is to maintain the pregnancy itself and to prevent, of course, ovulation. So when the blastocyst implants in the day 7 of pregnancy, you'll have the cells that surround this blastocyst, and the other cells, which is the syncytial trophoblast, is starting to secrete human chorionic gonadotrophin, which is going to be stimulating the corpus luteum to secrete estrogens and progesterone, which are basically growth hormones. And that will help to maintain a particular thickness in the endometrium so that the embryo will be supported while the placenta it is developed. Now, then that ACG is going to be antagonistic of FSH and LH to stop the ovarian cycle. Why will a female will have FSH if it's already pregnant? No purpose of stimulating more oocytes to be developed. So that's why ACG prevents FSH, and then of course LH, because LH helps for the actual ovulation. So there is no need for ovulation. Now, by the end of the 4th month, HCG secretion declines, and the corpus luteum is not longer needed. And that happens because, in this case, you already formed the placenta, which is going to be the source of these growth factors, which is the estrogens and progesterone. Now, we also have other hormones present, like relaxin, that prevents the contraction of the uterus when it's not needed. So that's why it's called relaxin. So that also helps not only to prevent contractions of the of the uterus, but also helps for the relaxation of the pubic symphysis and the sacroiliac joints. Why? Because the baby is growing, and then you have to have more space in your pelvic cavity to allow for this growth to happen. And then we also have the presence of human placental lactogen, or HPL, and human chorionic somatotrophin. So these two stimulate the breast development and prepares the mammary glands to secrete milk. But of course, we have prolactin that is coming from the pituitary gland to help to stimulate, in this case, the formation of milk. And then we have MSH cells that basically they are located in this pituitary gland that sometimes they are overstimulated, and they will secrete these cells, MSH, so that you will have increased pigmentation of the areola and the nipples. And sometimes it can produce, in some women, not in all, some patches of skin in the face that are darker, that is called melasma. Before I move on, don't ask me why, because I don't know. But it happens. Sometimes the male also get melasma and also get morning sickness, and the female might not get it. I have seen it before, and it's incredible. And then when the pregnancy is gone, melasma is gone, of course, morning sickness is gone. Can be through kissing, maybe, transferring of hormones can be, but no one knows why. Now, we also have CRH, which stands for corticotropin releasing hormone, that basically it helps determine the length of pregnancy and the timing of the childbirth. So this one stimulates the adrenal gland to secrete cortisol. And cortisol is necessary for maturation of the fetal lungs and the production of surfactant. Now, close to childbirth, the adrenal gland of the babies actually produces cortisol, which stimulates the baby to try to go through the birth canal. Now, prolactin is the hormone itself that stimulates the production of milk by the mammary glands, and then oxytocin, it is the hormone that helps to contract the muscle that surrounds the alveoli in the mammary gland so that you have the secretion of the milk. And then this oxytocin as well, what it helps during childbirth is the contraction of the uterus so that the baby goes through the birth canal. And then we also have presence of aldosterone that helps to increase blood volume. Blood volume helps for the baby to have, of course, in the case of the mom, for the mom to have more blood supply of oxygen to the baby and nutrients. And then we have the PTH, parathyroid hormone, that helps to increase the calcium levels in the mother so that the baby can have calcium to start ossifying its bones. And then also to contract the muscles. So those are hormonal changes. Now, anatomical and physiological changes. Of course, the uterus enlarges, and then it starts increasing intra-abdominal pressure, and then by week 40, this can reach up to the xiphoid process in the sternum, and that compression of the organs in the abdominal cavity, in the pelvic cavity, especially the urinary bladder, leads to the female to go more frequently to the restroom. And then you have as well hypertrophy of the myometrium to hold better the volume, and as well the placenta grows, and then you have accumulation of amniotic fluid. Then by month 7, the uterus is superior to the umbilicus and displaces this organ superiorly, which compresses the diaphragm, and then that also leads for the female to have kind of more increased respiratory rate, which in itself, I mean, if the baby needs more oxygen, what does the mother do? It breathes more. Okay, and then for the cardiac output, of course, that increases as well, because you have to bring more blood supply to the maternal blood vessels so that the baby can have oxygen available. And then something that happens is that many women can eat large meals, and then they can develop heartburn because of this compression of the stomach, which leads to the basically superior sphincter of the stomach, which is the inferior esophageal sphincter, to open a little bit more, and then acid reflux happens. And then with this weight that we have anteriorly, we can develop physiological lordosis, which is, if you remember, is exaggeration of the lumbar curvature of the spinal cord. And then mammary glands soar because they enlarge, they stimulate these nerves. And something that happens during lactation, it is contraction of these muscles in the around these alveoli, and then with oxytocin, this contraction is powerful, and that can lead to a little bit soreness, but the female get used to that. So then look at the changes here. So here we have non-pregnant uterus, urinary bladder not as compressed, diaphragm is way here up, and then mammary glands are not large. But in the first 4 months, the uterus become a little bit above the navel area. You start having compression of this urinary bladder, which can lead to more frequency urination, enlargement of the breast tissue in preparation for lactation, and then by 7 months, the uterus almost close to the diaphragm. Look at the urinary bladder is very compressed. Enlargement of the mammary gland continues, which is more larger by 9 months, and then the diaphragm definitely is elevated, and then this urinary bladder is so compressed during the 9 months of pregnancy. Cardiovascular system. So you have increased, as I told you before, of blood volume, like around 50% more, and then the cardiac output. Why? Because you have to deliver more nutrients as the baby grows, more calcium, and also more oxygen, because the tissues of the baby requires it. And of course, the baby will produce waste, which is going to be eliminated by the mother. And then that leads to all these changes. And then typically pregnant women have lower hematocrit than other women. This will decrease the resistance of the blood flow to the blood vessels, and that prevents also a rise in the blood pressure. Now, as the uterus grows, then that can compress also some of these blood vessels that we have, like the inferior vena cava, the iliac veins, and that can lead to poor return of the blood back into the heart, which can lead to edema in the lower limbs. And also sometimes varicose veins. Now, I don't know if it's going to bring that of the skin, but the skin stretches. And in some women, the elastic tissue of the skin, it doesn't give as much, and that leads to fracture of this elastic tissue, which can be seen as striations in the skin. Not all the women undergo that. And then some women can have several pregnancies, never had scars in their skin, but some others only with certain pregnancies. But maybe will be the last one, and that last one will lead to these scars. And then sometimes there can be problems in pregnancy, like preeclampsia. So that can be basically having insufficient blood flow to the uterus, or a problem in the mother's immune system. And that can be related to this number of fetal cells that enters into the maternal circulation. So in this case, it can be a problem, and then the fetus will be deprived of oxygen. Hypoxic baby is not happy, of course, and the mother can develop edema, hypertension, and proteinuria. That can lead to eclampsia, which is basically seizures, and that can lead to maternal and baby's death. And then the treatment of eclampsia will be to deliver the baby by C-section, and that's the remedy for that. So then preeclampsia can lead to eclampsia. And then we have as well respiratory system changes, in which, again, you have to increase the rate of respiration to compensate for the more CO2 that the female would have in its blood. And then the medulla in its respiratory center will become more sensitive to CO2 than usual. And then you will have prevention of the diaphragm basically contracting as much because you have the baby during the later stages of pregnancy up against the diaphragm, and then that can lead to more shallow breathing, although it's more increased, the breathing pattern, but it will be shallow because you cannot expand completely the thoracic cavity. And then the estrogen, something that they do is they swell the nasal mucosa. That can lead to congestion of the nasal mucosa and possibly epistaxis or nose bleeding. For the digestive system, a pregnant woman typically needs about 300 extra calories each day. And then it's supposed to have balanced diet with regular amounts of protein, calcium, iron, and folic acid, which is important for the closure of the spinal cord. And it has to be, of course, during embryogenesis, during organogenesis, when you are making these organs. So, given this, you can have an average weight gain of about 13 kilograms, which is 28.7 pounds. And then some women can have aversions to certain foods. Some of them, they can have cravings for certain foods. Apparently, those cravings are related to what we need in terms of nutrients. And then during the first trimester, again, because we have high levels of ACG and the female maybe has higher sensitivity for this ACG, the female will have morning sickness. And then that can be related to sometimes having what is called hyperemesis gravidum. Emesis by itself is vomiting. By hyperemesis is excessive vomiting. And that, unfortunately, it's a problem because, of course, I mean, who would like to be vomiting all the time, which is going to lead to losing electrolytes, losing weight, and poor nutrition for the baby. And then one of the things that is done to prevent also having low blood pressure in this case is to give an intravenous fluids. And then something that it can happen as well, it is relaxation of the smooth muscle and slow of peristalsis under the influence of progesterone, which can lead to congestion. And that's why it is advised, females by itself with very little liquid in pregnancy go a lot and pee, but it is advised to drink more water because of this effect of progesterone, of constipation. So because the baby is basically unable to excrete its own wastes, the wastes goes into a bloodstream, and then we have to clear up for the baby. So GFR, glomerular filtration rate during pregnancy increases, which leads to a raise about 50%, and that, of course, leads to more production of urine. And then sometimes with this compression of the urinary bladder can lead to stress incontinence and unintentional loss of urine. These problems then of the skin, as I told you before, is called melasma or cloasma. Basically a mass-like pattern, and we don't know why there is this more sensitive area in the skin in the cheek area and sometimes here in the dorsum of the nose that leads to pigmentation, extra pigmentation in this area. And then again, the stretch marks, the striae that can happen. Some people, again, will never have striae or stretch marks, while some of them with the first pregnancy, no matter that the baby is not having greater weight than what is expected, but it's the skin, it's the elastic tissue that it is very fragile that can break and causes that. And then the female itself, with these progesterone and estrogen levels, can decrease the normal hair loss, and the hair can become thicker during pregnancy. So any questions about the changes of pregnancy, during pregnancy? Okay, now for parturition, which is basically the birth of the baby. So you have several stages. Everything starts with the production of cortisol by the adrenal gland of the baby. And then that will stimulate the placenta to secrete these estrogens. And then high estrogen concentration will stimulate the formation of receptors for oxytocin in the uterus in preparation for labor. And the estrogen will override the influence of progesterone on the myometrium, which is relaxation. And then you will have some contractions, false contractions, that are called Braxton Hicks. That are called false contractions because these contractions are not strong enough. It's basically increasing the tone of the uterus, but it's not strong enough for expelling the baby from the uterine cavity. And then you will have then the production of this cortisol, then the baby will hit against, of course, if the baby's head is oriented toward the cervix, will hit against the cervical os, and that will produce a positive feedback from the mother's cervix so that the mother can generate more oxytocin. And with this oxytocin, you start contraction of the uterus in a fashion that starts very regular contractions, very mild contractions, not painful. And then as time passes by, there is an increase in the number of contractions and then in the intensity of the contractions. That will lead to dilation of the cervix and also to the release of these prostaglandins by the placenta. That dilation can take several hours to happen. It will end up in 10 centimeters, and that will be sufficient for the baby's head to basically be seen through this cervix opening, and that will basically helps for the exiting of the baby together with these contractions. Now, something that happens during pregnancy is that under the influence, you form a mucus plug in the cervix. And then during labor, this mucus plug will be discharged, and then you can have labor that can begin within hours and may not occur up to 2 weeks. The more pregnancies that the female will have, the more deliveries that the female will have, the shorter the process. And then the labor can be initiated or induced. If the female doesn't have enough levels of oxytocin, synthetic oxytocin, which is called pitocin, can be administered. And sometimes that is not enough to dilate the cervix. So in that case, a female ends up in C-section. There might be not enough receptors of oxytocin there. So that's the normal position of the baby with the head against the cervical os. And then that physical contact will stimulate the production of cortisol by the baby. That cortisol goes into the mother's bloodstream, and that will lead for the release of oxytocin by the pituitary gland, the posterior pituitary gland. That oxytocin goes into the uterus, you start having contractions. The contractions will increase in number and in intensity as time passes by. And then you will have high concentration levels from estrogen that stimulates the oxytocin receptors to form, so that you will have this positive feedback that begins the dilation of the cervix. So in the dilation stage, you will have up to 10 centimeters or 3.9 inches in diameter of dilation. So longest stage of labor is usually ranging between 8 to 24 hours. And then a female who has their first child, it takes longer time, of course, and then it shortens as it has more babies. So it can sometimes be within hours, few hours, sorry. So when the baby has the head against the cervix, is called vertex presentation. And then the amnion ruptures, so that's what we know as the water breaking. And then, or rupture of the membranes, and that basically is like the ultimate signal that the baby is about to born. And then once the head basically is seen through the cervical canal, then the head enters into the lesser pelvis. The baby is going to rotate, so it would start like this, and then goes up. So the face first looks down, and then rotates to the right, and then goes up, and passing through the pelvic outlet. So the contractions of the uterus can be aided by the contraction of the abdominal muscles. So this is known as pushing, and typically ranges from 30 minutes to 1 hour, but it may take a few hours for the expulsion stage to happen. So we move from dilation into expulsion, which is basically the process of actually helping for the baby to go through the birth canal. And then the baby's head, when it's seen through the vagina, is called crowning, or in the vestibule. And then depending on how big is the head of the baby, and then thinking about that not only the head of the baby passes through there, but also the shoulder to shoulder dimension passes through there, is whether you will make an episiotomy or not. I mean, typically episiotomies are done, which is basically cutting a little bit the perineum with the scissors to prevent rupturing of the muscles there and the tissues without having a lot of tear. And then after that, you will, of course, stitch. So once the baby is born, you cut the umbilical cord, you clean the baby, and then you clamp the umbilical cord. And then if the baby is maybe not in vertex position, maybe the baby has the umbilical cord wrapped around, or something is happening, then you have to do a C-section. Sometimes the position is with the buttocks first birth. This is called as bridge birth. And then it can born, but it's more difficult. It takes more labor. The longer the labor that it takes, guys, the greater the chances that the baby will have problems of oxygenation. So that can lead to nervous system problems. So then the C-section then will be made to help for the baby to born. After expulsion, you have to get rid of the placenta. So this is the placental stage. You have to make sure that all the membranes, the extraembryonic membranes, comes out. Because if you leave part of the placenta in the uterus, that is going to lead to infection, and that can lead to maternal death. It takes around, if maximum, 30 minutes for that to happen. If not, that has to be 8. It has to be removed manually. Part of the umbilical cord, once you cut it, it will be long enough to pull the placenta, and that will have to be all, but sometimes if the placenta doesn't come complete, you better take it out. So then these are the stages of labor. So you start here with this baby in vertex position, then you dilate. This is the dilation stage, and then the expulsion, and then the placental stage. Now, for changes in the newborn, we have the neonatal period, which is the first 4 weeks after the baby has born. And the baby in this stage is called the neonate. And then once the baby borns, you have to check at first in 5 minutes the reaction of the baby, if it's having a normal reddish color, if it's breathing, the muscular activity, the grimace, the pulse rate, which is higher in babies. It's like 100 beats per minute. So this is what is called the APGAR score. And then you have 5 categories, which includes skin color, which is reddish versus bluish. Bluish means that it has cyanosis. Pulse rate, greater than 100 beats per minute or lesser than that. Respiratory level, does it make the effort or doesn't make the effort? When the baby born and it's basically crying out loud, because of course who likes to go out from a warm place and full of lights and all that, cold. So when the baby's crying, at the same time it's gasping for air, and you can see that in the baby. So that tells you two things at once: the respiratory level and the muscular activity, and grimace, which assesses the reflex. So you can grab the hands of the baby and or the feet of the baby, and if it pulls, that's assessing a reflex. So each of these is given 0 to 2. You add them all up, and then if you have above 8, it's a good score. And then 8 to 10 means healthy baby. Lower than that, you have to make sure that everything is fine. Of course, the lower the level, you don't wait to give assistance for the baby to live. So here is the score. 0 for pale to blue color in the skin. No pulse is 0. No breathing is 0. And then flaccid muscles, 0. No response. The reflex involving the face and body, it's 0. 1, limbs blue, body pink. And then 4, pulse rate, 100 beats per minute or fewer. Respiratory level, slow or irregular breathing, weak cry. Muscle activity, some movement, poor muscle tone. Facial grimace, some body movement for 1. 2, pink with dark skin. for skin color, for pulse rate over 100 beats per minute, respiratory level, normal, regular breathing, strong crying. Muscle activity, active movement, good muscle tone, facial grimace, significant body movement. So the baby starts kind of moving their limbs very fast. And again, it has to be done at first minute after you're born and 5 minutes after you're born. Changes in the newborn. So basically the alveoli inflate during the first breath. Hopefully you have enough surfactant so that the alveoli doesn't collapse. And then that decreases the blood pressure in the lungs. And then in the right side of the heart, that basically it is connected to the left before we're born, you have the pushing of the flaps over the foramen ovale to close the connection between the left and the right side, and that leaves the fossa ovale, which is the remnant of the foramen ovale. And then you will have the blood supply going into the lungs, because the baby's lungs now are filled with air and then can oxygenate some blood. And then you shut down the ductus arteriosus, so you make the ligamentum arteriosum. You shut down the ductus venosus, that becomes the ligamentum venosum. And then the respiratory rate in neonates is very high, 30 to 60 breaths per minute. And then the heart rate is between 120 to 140 beats per minute. Why? Because they have very low lung capacity, and then their cells are constantly replicating, so they have to breathe more, and then they have to provide more blood supply to their body. Now, the newborns, they lose body heat more rapidly than adults because they have a lot of circulation, but they have this brown fat that helps them to maintain this body temperature. They have this subcutaneous tissue with this brown fat, and then as it grows, the baby, as it's increasing the size of their tissues, the adipose tissue starts being lost, and then the kidneys are less capable than the adult's kidneys to concentrate the urine, so they require more fluid intake than an adult. And then the babies will have near adult levels of IgG antibodies that were coming from the maternal blood supply that last for around 9 months or so. So while the baby is crawling, it will grab objects, put it in their mouth, exploring the world, getting in contact with several antigens, forming their own antibodies. So, but the first 9 months, the mother gives the IgG. And then if the baby was breastfed and is breastfed, it will have a second supply of antibodies, which is IgA. That especially comes in the colostrum together with the IgG. So again, I already mentioned this. So your ductus arteriosus is supposed to become the ductus venosus. Sometimes, unfortunately, this doesn't close, and then you will have poor oxygenation of the blood of the baby. And then that needs to be closed because it can damage the heart and the lungs. So that can lead to cardiac dysrhythmias and potentially heart failure. So you have to perform a surgery to close that. And then what will happen if you keep the foramen ovale? Same deal. You dilute the levels of oxygen that you're supposed to have on the left side. So that can lead to also more blood supply on the left side, which can lead to more friction between the erythrocytes, leading to the formation of blood clots, which increases the chances of having circulatory problems. Now, changes in the mother in postpartum. Well, the endorphins are released by the pituitary gland, which basically explains why the mother feels relaxed after the baby borns, and as well, the mother ignores fatigue and pain for caring of the newborn. And then the levels of estrogens and progesterone fall. And then your corticotrophin releasing hormone also declines because the placenta is not there to stimulate for the formation of this. And then the female will have sometimes reduction of these hormones so much that it can lead to postpartum depression. So now, once the baby has born, the respiratory and digestive system returns to the normal function. Then sometimes the female will have more excess of fluid retained during pregnancy, but after the baby has born, these levels of fluid, they're supposed to return to normal. And then the skin pigmentation also returns to normal. If there are varicose veins that were formed, those ones doesn't go away. Of course, the same for the striae or the stretch marks. And then for lactation, well, if the female is lactating, the female will have the release of this of prolactin, which maintains this production of milk, and then the female will require the intake of more nutrients to keep forming normal levels of milk. And of course, after the baby grows more and basically is eating more, there is no way that the mammary gland itself will be able to satisfy the baby. So in this case, you can introduce some formula. And then in the case of the formation of milk, it happens because there is a positive feedback that leads to the release of this prolactin and this oxytocin. So when the baby's sucking the nipple, that leads to a positive feedback into the hypothalamus and also into the cerebral cortex, so that the hypothalamus produces this oxytocin, and also you have the release of prolactin by the pituitary gland. Now, the baby, once it borns, is going to have its first release of shedding of the digestive system, the poop of the baby. The first poop is called meconium. It's going to be green material that comes from the degradation of the cells of this internal part of the epithelium of the digestive system, plus accumulation of bile and other wastes. And then oxytocin, it is part of the letdown reflex. So again, we have the infant suckling that triggers the hypothalamus to produce oxytocin. Then your anterior pituitary gland produces and releases prolactin. And then oxytocin contracts these myoepithelial cells, which lead to the release of milk. And then you keep having this positive feedback that you can see here. So suckling of the baby stimulates the hypothalamus, and then the cerebral cortex, which is not shown in here, and that leads to the release of prolactin and oxytocin. There is this, of course, emotional bond. Sometimes some females, they can have automatic release of milk after just hearing the baby crying or even thinking in the baby. So that's normal. So that's all for this chapter. Do you have any